The need for widespread, easily accessible HIV testing for adolescents is clear. I'm not going to deny that. I'm certainly not arguing to limit access, as my opponent claims. So we know that adolescents disproportionately represent incident infections worldwide. And in sub-Saharan Africa, only 1 in 5 adolescent girls know their HIV status. But is self-testing the solution for diagnosing all adolescents? No. So let's just talk for a moment. This is an exciting testing modality, and Cheryl Johnson has gone through some of the data behind this. But what is exciting for sure about HIV self-testing is you can think of it as a move from you have health facility clinic-based testing, and certainly the limitations there, and clearly going to out-of-facility community-based testing has had major advantages in terms of access, reaching people where they are, and improving HIV testing access and normalizing HIV testing. The excitement around this relatively new technology is this idea of moving out of healthcare. And while that's exciting, it brings up the opportunity for unsupervised self-testing. It does carry with it some risks, and they're worth considering before making a recommendation that this is what should be implemented for all adolescents. All right, so before deciding one testing modality alone is the right fit for all, let's really consider the trade-offs involved. Anytime there's a brand, something new and exciting and innovative, you want to dive in, but consider risks and benefits as we do as clinicians. So some of the benefits that have been described are autonomy, privacy, anonymity, perhaps that increases demand. This avoids a health center and a clinic interaction, and that's great, right? Because then you don't have to come in, and we know that can be a deterrent, seeing a big, scary hospital sign, for example. It's described as acceptable and easy, and allows for partner testing. But what are some of the potential risks and unintended consequences before we make this recommendation? Well, first of all is lower linkage to care and treatment. We know that adolescents are at higher risk of not linking to care and starting ART after an HIV-positive diagnosis. Linkage to care rates are lower, and there's lower retention and viral suppression rates. For example, if you compare the care of cascade of care in the United States, whereas adults hit about a 30% product at the end of the cascade that are virologically suppressed among all HIV-infected persons, this is 6% in adolescents. Similarly, this is in the search trial in Kenya and Uganda and East Africa. When you look at retention in care at 1 year, and I'll focus here on newly diagnosed, I don't have a cursor, among newly diagnosed people, the probability of being retained at 1 year is really lowest in those 15 to 24 years, dramatically more so as you get older. The same trend held in those who were previously in care being retained in clinical care. So we know that the adolescents will link at a lower rate. We also know that they'll retain in care and start ART at lower rates. But what do we know about linkage after HIV self-testing? The answer is little. In a recent systematic review by Cheryl Johnson, they're supporting evidence for HIV self-testing in the Journal of International AIDS Society in a systematic review is low and limited evidence. So after 2 years of promoting HIV self-testing in Malawi, for example, we know that 76% of self-testers shared the results and 42% of HIV positive linked to care, but there's really little or no data, at least that's been shared, on what is linkage after HIV self-testing in adolescents who have tested HIV positive. So the takeaway point here for risk number 1 is really it's important to study linkage and treatment after self-testing further before we start recommending this as the testing modality for all adolescents. And I think the takeaway is really that adolescents need more support when testing, not less, especially if they're newly HIV infected. All right, so unsupervised testing is also a major missed opportunity for health prevention education. Sexual and reproductive health education is clearly lacking for adolescents in many settings. In population-based surveys worldwide, 24% of young women, 36% of young men responded correctly to 5 questions on HIV prevention and transmission. And clearly, if you search the web as to just what people are typing in and trying to figure out about sex, there's a lot of questions that are going unanswered. And maybe a vending machine or a pharmacy is not the place to figure this out. Similarly, when you look at high-burden countries, the proportion of 15 to 19-year-olds, sorry, this got cut off in the Mac to PC transition, but with comprehensive knowledge around HIV is clearly below 50%. So leaving adolescents really on their own to figure out self-tests in an unsupervised setting is a huge missed opportunity. Remember, HIV is, of course, not, I don't have to tell this audience, but it's not the only health-related issue for adolescents. It could be questions around sexual debut, pregnancy, STIs, education, prevention, depression and anxiety, and many may not realize they're at risk of other problems or HIV alone, and HIV self-testing as a result does not address low health literacy, and remember, unsupervised therefore represents a missed opportunity. Okay, so user error. You'll hear again and again, oh, it's really easy to use, and it's true, most initial data suggest that HIV self-tests are relatively easy to use. But this was presented at CROI this past year. Assessment of user understanding of packaged instructions for use. These are among 20 literate adults who are given OraQuick with no other assistance. I just want to highlight one clear problem. Over a third couldn't even open the package. We got a problem here. So although it's exciting that younger people might be a little more capable of technologies, that's a problem. What do we know about how this might impact sensitivity? There is an RCT performed in Uganda fisherfolk comparing unsupervised versus provider-supervised oral tests in 246 adults by Asimwe et al. And in the unsupervised group, there was a 10% drop in sensitivity in the intent to treat analysis. So they were unable to conclude that this was a non-inferior strategy. Similarly, if you look at what kinds of help people needed, in the unsupervised group, 24%, pretty high proportion, reported needing some form of additional help. And then if they're supervised and they had opportunity to ask, 42% requested additional help. Let me just point out that even the former US president was apparently unable to HIV self-test without assistance. All right, so, risk number 4, the window period. So false negative results could equal false reassurance. So it's not that the window period is unique to HIV self-testing. It clearly exists with rapid tests. However, when we think about unsupervised testing and what the allure may be, what does this potentially mean? So the window period, I think all of you know, but it refers to this 4 to 12-week period between HIV infection and then antibody detection with rapid tests. And clearly we know this can result in missed acute and early HIV infections. And we know that adolescents are a very high-risk group for incident HIV, particularly young women, and young people may lack data on the window period. Clearly, serosorting and condomless sex after negative HIV self-testing has been reported. It's part of potentially the attraction to using this test is to test with a partner. And in one example that enrolled Kenyan women, this study by Thirumoorthy et al., 56% of women reported condomless sex after a negative HIV self-test in an RCT in Kenyan women. This included sex workers, again, another high-risk group. On that basis, the current WHO HIV self-testing guidelines say that serosorting following HIV self-testing is not recommended in population groups with high HIV incidence. So the take-home point for this risk is that adolescents are a high HIV incidence group, and that false negative results in the window period with condomless serosorting is potentially a problem and maybe an argument against moving forward with unsupervised testing without further kind of understanding of how this test is going to be used. All right, I'll be brief on coercion and intimate partner violence. It is true that the data, thankfully, are so far reassuring for adults as well as adolescents in Malawi. I don't mean to be fear-mongering here, but do really have enough data in adolescents, particularly in a whole variety of settings, for young women in particular, to know that this is likely to remain a rare outcome. Now, finally, I want to talk a little bit not about limiting access, but what is the benefit of testing with a provider? And I don't mean that this has to be a doctor sitting in front of a clinic, but interacting with someone with healthcare knowledge. Benefit number 1, to keep it simple, is that if you're HIV infected, you can this can facilitate linkage and prompt treatment. We know that prompt ART start can be life-saving. In many settings, median CD4 diagnosis is quite low. And we know in multiple studies now that decreasing time from testing to treatment, including same-day ART start, may increase retention and care and improve outcomes. And we know that also, of course, you can provide counseling and support for post-diagnosis, something not available if you have an unsupervised test out on your own. Benefit number 2, you can provide combination biomedical prevention interventions, such as access to PrEP, in a variety of methods, condoms, teaching about male circumcision. It's a little bit hard to imagine the vending machine be required if you had to have your surgeon, your PrEP, your counseling, and your OraQuick all in one vending machine. So, and then finally, benefit number 3 of testing with a provider. And this is really getting back to this question Cheryl Johnson brings up. It is true that we have now a number of modalities that do work in reaching a large proportion of the population, including hitting the first 90. These are some data from the SEARCH trial, of which I participated, where we showed that you could reach the 90% mark across a wide range of young adolescents up to young adults. And if you look at the increases in testing rates, both in Kenya, here in the blue dotted line up to what we achieved, and Uganda up to the red dotted line, not only are high rates of HIV testing achievable, but they're measurable with community health approaches. And really, I think the key to hitting these marks with a community health-based approach is not to decrease access, but it's actually to improve access to more than just HIV care. And it's to meet people where they are, and that can include fishing villages, it can include bars, it can include moonlight campaigns to reach people after work hours, and certainly don't just make it about HIV, but potentially link HIV to other things that are appealing, whether it be sporting matches here in the case for young men or multi-disease services. So in summary, it's always tempting to think of a new innovative technology as the solution and to be an early adopter, but there are many risks, especially unsupervised, that I've gone through. And there are many benefits with other community-based HIV testing and counseling approaches. So avoid one-size-fits-all thinking and vote no, a con on this proposition. Thank you.